So Lucas asked me to talk about what's new in the management of spinal trauma. Some of this may not be too new, but I guess some of it may still be. So my disclosures should not matter. I'm going to talk only very briefly about surgical technique, talk a bit about MRI, about timing of surgery, central cord syndrome, and something about monitoring and decompression of the spinal cord. Surgical technique, this has been mentioned already in the last few lectures. When we were confronted with A3 fractures, A4 fractures in the past, quite often we would be going for conservative care, and we would do people would try bracing, which I never really believed in. And what we do nowadays is that we tend to go for percutaneous screws in those borderline compression fractures. And we already know that when we position those patients on the OR table, the reload dosing is working right there. And so realignment is usually done by positioning. And it has always been argued that you need monoaxial screws to use ligamental taxis in those patients to realign them properly. But there are nice studies out there now, 5 years old, that you can also use MIS polyaxial screws to get the same result. And also this result is long lasting. What we do nowadays is that for most of those patients, if not all of them, we use, even in a percutaneous fashion, a short low-dosing screw in the fractured vertebra. And by doing this, you can reestablish lordosis even more accurately. And the results are quite good. What we use, like Marcel has shown already, for most of these cases, we would try to go for navigation to use MIS surgery. And this is two of those short screws you see there in the middle, implanted through a navigated MIS approach. And there is some good data out there in a meta-analysis of several hundred patients that the short-term outcome is better, less blood loss, shorter surgery, less infection, whereas the radiological correction is the same and outcome is better than with open techniques. Secondly, when do we need an MRI? This still is a burning question, whether you can go with a CT only in spine trauma patients. But we know from several studies that in about half of the patients, you will get additional information when you get an MRI. This may be spinal stenosis at another level. This may be posterior ligamentous injury. And this is just from one paper that found adjacent stenotic segments in 7%, distant disc herniation in 16%, and in up to 30–40% of your patients, an additional MRI will change the classification of your injury. And this means that you will, particularly in older patients, patients with spondylosis, patients with neurologic deficit, and obviously those that are unconscious where you don't know they have a deficit, they should undergo MRI. Whereas a young patient, neurologically intact and awake, a CT scan is definitely going to be fine. And it's even more discussed if you have a cervical facet dislocation. Do you need an MRI before you reposition the patient and before you do a reduction? And obviously a con would be that you lose time if you do an MRI. And we know from studies that are quite old that the risk of injury by reducing the patient, even if there is a disc herniation, is very low. And also there's a risk to the MRI. The patient is transported there. This may also be a potential problem in those highly unstable patients. And the advantages are you can identify the traumatic disc herniation. If you make a mistake and the patient is tetraparetic afterwards, it's obviously a dramatic consequence. And as I said before, the MRI gives you more information on the approach in any case. But there have been studies out there showing, this is from Australia, if you do an MRI, you lose on average 4 to 5 hours. But they also showed that the most lack in timing, or the most loss of time, was due to looking for an OR or an OR team. So what we suggest now is that you go with your patient that has the CT scan from the emergency room, you go directly to the MRI, and while the patient is in the MRI, you prepare the OR. And then you don't have an extra loss of time. And this works very well if you plan the logistics perfectly. When should surgery be performed? You all know, once upon a time, when we all were trained, we thought the lesion of the spinal cord happens at the time of impact. If we operate the patient early, he will be very vulnerable to complications. And in a complete injury, it doesn't make a difference anyway, because the patient is never going to recover. But we know now from many studies, this shows the Asia grade conversion rates, the improvement of patients, even if they're complete, there are adequate improvement rates. And this is for an average population not treated early. And the landmark studies of failing some 10 years ago now showed that if you operate within 24 hours, we have more patients that do improve by, for example, here, more than 2 AIS grades. And this has been nicely shown in a meta-analysis as well, that if we end up having, if we end up treating patients within 24 hours, our total motor score and our neurologic improvement will be better than treated after 24 hours. And what is also important is that newer studies looking at 12 hours as a time threshold, they've shown an improvement overall of 73% of patients versus 44%, or, and this is a very important message, in complete spinal cord injury, 62% of patients that were operated early improved, and almost nobody improved after 12 hours for those complete injury patients. And another study looked at this statistically, and they found a window of opportunity of 4 to 9 hours. If you operate patients within 4 to 9 hours, they have a good chance of recovering maybe even 2 AIS grades or more. So this is a dramatic difference for those patients. And this, again, is an Australian study showing the dependence of the recovery in relation to timing. And they particularly had a few patients with closed reduction, meaning those patients with cervical facet dislocations were reduced right away within the first 2 to 3 hours. And those patients did extremely well. So we can say now that time is spine, and this is very important. So the next step was that others, also one of my team members was involved in this. They looked at operating within less than 8 hours, and they found, again, a significant difference. And what is very important, that 50% of the patients that were treated very early recovered by at least 2 AIS grades, so that the old paradigm that we thought of has changed. And now in incomplete and complete injuries, we know early surgery is beneficial. And there was also a paper by the Fehlings group on this in Lancet Neurology, where I was able to do an editorial on that, basically showed the same thing, even though this is only the 24-hour data, which I think is poorer than the shorter outcome data. What about central cord injury? Central cord syndrome is something that happens usually if we have cases with pre-existing multisegmental stenosis. And we know now that spinal cord injury is most common in older patients. That's the most endangered age group, as you can see also here. And this is data from 2013. The curve for the older population with spinal cord injury is going up like this, where the others luckily are going down. And the mean age now, it was 25 years in the past. Now it's more than 50 years, mean age of traumatic spinal cord injury. So the central cord syndrome will be the most common injury we are facing as surgeons. And we all still talk about it as the Schneider's paresis, which was published 70 years ago. And back then, it was believed that those patients recover spontaneously and outcome of surgery is poor. Obviously, in the 50s, the surgery on the cervical spine was very brutal, if you will. And so nowadays, still many neurologists say, let's see how the patient recovers in the first few days. But there's good data out there nowadays that the patients don't always improve, only half of them improve. And several patients actually decline in the first few days neurologically. So the old Schneider's paradigm is not true. And we also know if we do surgery on them early, outcome recovery rate is better than we do surgery late. And this has also been studied in a recent meta-analysis that I just want to show you quickly here. So central cord syndrome, according to me, which may still be a personal view, is that the historical analysis is no longer valid. We have older patients that recover poorly. We are much better in perioperative care, much better in surgery. And that's why we follow a rule that we do surgery within 24 hours, because this is safe and reduces complications. The old patients will be worse on day 2, 3, 4, the longer you wait. And surgical damage nowadays is very rare. We tend to do them from posterior, but you don't have to, obviously. The final point I quickly want to point out is that from the Papadopoulos group at St. George's, we have learned that if we measure interspinal pressure at the level of injury, that this can be quite high, just like we've learned from traumatic brain injury. And if we have low pressure in the spinal canal, those patients improve much better than those that have a higher pressure. And also, spinal cord perfusion pressure is very important. So we need to put a lot of emphasis on mean arterial blood pressure. And the odds ratio for a poorer recovery rate is dramatic if you increase interspinal pressure or you decrease spinal cord perfusion pressure. The same is true for blood pressure control on the ICU. And I would like to show you that, therefore, we think we should monitor those patients for quite some time because we want to keep up spinal cord perfusion pressure. And there's also interesting data on intraoperative blood pressure. We as surgeons tend to want to have a low blood pressure so we don't have that much bleeding, particularly in traumatic injuries. And this data nicely shows that patients that had blood pressure values outside this optimum range didn't improve as much as others. And this is even the most important publication on blood pressure and traumatic spinal cord injury, I feel. Pre-hospital, it's very important. It's most important in the operating room. And then it's also important early on the ICU, and then it becomes less important. And to be honest, if you look at the values, how important this is for outcome, it's more important to have an adequate blood pressure during surgery than how you perform the surgery, whether you go front, back, or whatever technique you use. So even though we surgeons don't like to hear that. And decompression, something we've also learned in the recent years, is that if you do an anterior decompression and we would do an MRI within the first 2 days, we only decompress about half of our patients from anterior sufficient decompression, meaning that you have a rim of CSF around the spinal cord, which might often may be swollen, but you actually would need an additional laminectomy to have a wide decompression of your damaged spinal cord. And therefore, this is also from the Papadopoulos group, they went even further, not only looked at laminectomies, but they looked at laminectomy and duroplasty to decompress the spinal cord. So this is something that's currently under investigation, whether this makes sense to do in certain patients, particularly in the cervical spine. So in summary, what's new? I think nowadays we have optimized the minimally invasive surgical techniques that you can use with navigation. We personally perform much less conservative treatment for like A3 or A4 fractures and use more percutaneous screws, which is a 30-minute operation. There are logistical improvements in spinal cord injury care, time is spine, ultra-early surgery, rapid MRI, and then also optimized blood pressure and spinal cord perfusion pressure. We all have to be aware that central cord syndrome is going to be the most common spinal cord injury type. No doubt in a few years this will be the case. I think it should be treated early within the first 24 hours, but this is still a matter of debate. And don't only think about surgery, think about those blood pressure and perfusion parameters. Also intraoperatively, they seem to be more important than we believe. And I thank you again for the invitation, and glad if you do have time to take a couple of questions. Thanks a lot.